Question 1. A confused older adult keeps trying to get out of bed unassisted. Which initial nursing action best prevent a fall? A. Perform a fall risk assessment and implement individualized precautions. B. Apply bilateral wrist restraints immediately. C. Turn off bed alarms to reduce agitation. D. Move the patient to a shared room for observation. Answer. A. Perform a fall risk assessment and implement individualized precautions. Rationale. Assessing risk first guides targeted interventions, low bed alarm on, frequent rounding, toileting schedule, non-skid footwear. Restraints increase injury risk and must follow strict indications and alternatives. B. Disabling alarms removes a key safeguard. C. Room changes without a plan do not address specific risks. D. Question 2. Before administering insulin, which action is the safest to prevent a medication error? A. Verify the patient's identity using 2 identifiers. B. Ask the family to confirm the dose. C. Administer if the patient verbally agrees. D. Skip the double check for high alert meds when busy. Answer. A. Verify the patient's identity using 2 identifiers. Rationale. 2 identifiers, name, DOB, MRN, ensure the right patient, critical for high alert meds like insulin. Family verification is unreliable and not a standard. B. Verbal agreement alone is insufficient. C. Skipping independent checks for high alert meds increases error risk. D. Question 3. A nurse enters a room with soiled hands after removing gloves. What is the most appropriate next step? A. Perform hand hygiene with soap and water. B. Place new gloves over soiled hands. C. Wipe hands with a dry paper towel. D. Use alcohol gel only if hands are visibly dirty. Answer. A. Perform hand hygiene with soap and water. Rationale. Visible soil requires soap and water. Alcohol gel is ineffective against certain pathogens, and when visibly soiled, A. Gloves over dirty hands do not prevent transmission. B. Dry towel does not remove contaminants. C. Alcohol gel is not recommended with visible soil. D. Question 4. When moving a bariatric patient from bed to chair, which action best supports safe patient handling? A. Use a mechanical lift with adequate trained staff. B. Ask the patient to ambulate independently. C. Pull the patient by the arms with 2 nurses. D. Encourage the family to help lift. Answer. A. Use a mechanical lift with adequate trained staff. Rationale. Mechanical lifts reduce musculoskeletal injury and patient falls. Ensure correct sling and sufficient trained personnel. A. Independent ambulation may be unsafe. B. Pulling by arms risks injury. C. Family assistance without training is unsafe. D. Question 5. A bedside cardiac monitor alarm is sounding. What is the safest priority action? A. Assess the patient immediately to determine clinical status. B. Silence the alarm and continue charting. C. Disable alarms to reduce false positives. D. Wait for the monitor tech to call. Answer. A. Assess the patient immediately to determine clinical status. Rationale. Alarm response begins with patient assessment. Treat the patient, not just the monitor. Silencing or disabling alarms delays detection and risks harm. BC. Waiting defers responsibility in an urgent situation. D. Question 6. A nurse discovers a near miss where the wrong antibiotic was prepared but not given. What is the best action? A. Report the near miss through the safety event system. B. Ignore it since no harm occurred. C. Blame the pharmacy for the mix-up. D. Document only in the progress note. Answer. A. Report the near miss through the safety event system. Rationale. Reporting near misses enables system learning and prevention. Just culture supports transparency. A. Ignoring blocks improvement. B. Blame undermines safety culture. C. Progress notes alone won't reach quality systems. D. Question 7. Which action prevents wrong patient errors when collecting lab specimens? A. Confirm 2 patient identifiers and match to the label at the bedside. B. Label tubes back at the nurse's station. C. Ask the roommate for the patient's name. D. Use room number as a second identifier. Answer. A. Confirm 2 patient identifiers and match to the label at the bedside. Rationale. Bedside labeling with 2 identifiers reduces mislabeling risk. A. Central labeling increases mix-ups. B. Roommates are not reliable identifiers. C. Room number is not an approved identifier. D. Question 8. Which intervention most effectively reduces catheter-associated urinary tract infection (CAUTI) risk? A. Remove the catheter as soon as it is no longer clinically necessary. B. Increase bag emptying frequency only. C. Keep the catheter for convenience of intake or output. D. Disconnect tubing for patient mobility. Answer. A. Remove the catheter as soon as it is no longer clinically necessary. Rationale. Early removal decreases infection exposure. A. Frequent emptying is helpful, but insufficient alone. B. Convenience is not an indication. Unnecessary catheters increase risk. C. Disconnections introduce pathogens. D. Question 9. Before giving potassium chloride, IV, what is the safest verification step? A. Confirm it is diluted and use an infusion pumper policy. B. Push the dose rapidly to save time. C. Mix with dextrose and give IM. D. Administer without checking recent labs. Answer. A. Confirm it is diluted and use an infusion pumper policy. Rationale. IV KCl must be diluted and controlled to avoid arrhythmias. Verify rate, concentration, and recent potassium or renal labs. A. Rapid IV push is contraindicated. B. IM KCl is unsafe. C. Skipping labs increases harm risk. D. Question 10. Which action best reduces pressure injury risk in an immobile patient? A. Reposition at least every 2 hours with skin assessment. B. Keep heels directly on the bed for stability. C. Limit moisture barriers to prevent maceration. D. Avoid nutritional screening to reduce tasks. Answer. A. Reposition at least every 2 hours with skin assessment. Rationale. Scheduled repositioning and skin checks prevent pressure injuries. Include heel offloading and moisture management. A. Heels should be offloaded, not pressed. B. Moisture barriers help prevent breakdown. C. Nutrition screening is essential. D. Question 11. A pre-op patient states a penicillin allergy. What is the safest immediate nursing action? A. Hold ordered ampicillin and notify the provider. B. Administer the antibiotic and monitor closely. C. Ask the patient to sign a waiver. D. Remove the allergy band to avoid confusion. Answer. A. Hold ordered ampicillin and notify the provider. Rationale. Penicillin class cross-reactivity warrants holding the drug and clarifying allergy details or alternatives. A. Giving despite allergy risks anaphylaxis. B. Waivers do not replace clinical judgment. C. Removing bands increases error risk. D. Question 12. In a room with wet floors and frayed cords, what is the safest first step? A. Remove or tag faulty equipment and place a caution sign, then notify facilities. B. Continue use until a replacement arrives. C. Wipe the floor and ignore the cords. D. Ask the patient to avoid walking. Answer. A. Remove or tag faulty equipment and place a caution sign, then notify facilities. Rationale. Hazard control includes isolating unsafe equipment, warning signage, and prompt reporting. A. Continued use risk shock or falls. B. Partial fixes ignore electrical risk. C. Telling patients to avoid walking is not a control measure. D. Question 13. During medication reconciliation, which discrepancy demands immediate clarification? A. A home med listed as daily but ordered bid in hospital. B. A vitamin not ordered in hospital. C. A PRN med not used since admission. D. An OTC med discontinued per policy. Answer. A. A home med listed as daily but ordered bid in hospital. Rationale. Frequency changes can cause toxicity or underdosing. Must reconcile with prescriber. A. Vitamins or OTCs may be intentionally stopped. Not urgent if not clinically critical. BD. PRN non-use is not a discrepancy. C. Question 14. Which delegation by an RN to an experienced UAP is appropriate for fall prevention? A. Instruct UAP to implement hourly rounding and report changes. B. Delegate assessment of orthostatic hypotension. C. Ask UAP to decide when to remove restraints. D. Have UAP create the fall prevention plan. Answer. A. Instruct UAP to implement hourly rounding and report changes. Rationale. UAP can perform routine tasks, rounding, toileting assistance, with RN oversight. RN retains assessment or plan responsibility. A. Assessment and clinical judgments are RN roles. B, C, D. Question 15. A nurse misprogrammed a PCA pump dose. The patient is stable. What is the safest next step? A. Stop the PCA, assess the patient, notify provider, and file an incident report. B. Adjust quietly and avoid documentation. C. Apologize and continue therapy without changes. D. Remove the pump to hide the error. Answer. A. Stop the PCA, assess the patient, notify provider, and file an incident report. Rationale. Immediate patient safety, transparent reporting, and corrective action uphold just culture and prevent recurrence. A. Concealment undermines safety. B, C, D. Question 16. Which action most effectively reduces CLABSI risk during central line dressing change? A. Use sterile technique and chlorhexidine for skin antisepsis. B. Wear clean gloves and alcohol wipes only. C. Change dressing only when visibly soiled. D. Allow tubing to rest on unsterile surfaces. Answer. A. Use sterile technique and chlorhexidine for skin antisepsis. Rationale. Sterile technique, chlorhexidine prep, and maintaining a sterile field are key CLABSI preventions. A. Clean technique is inadequate. B. Scheduled and as-needed changes are required. C. Unsterile contact increases contamination. D. Question 17. A patient with dementia wanders at night. What combined strategy best prevents injury? A. Low bed, bed alarm, night lighting, and scheduled toileting. B. Sedative at bedtime for all nights. C. Lock the patient's door from outside. D. Remove assistive devices to limit mobility. Answer. A. Low bed, bed alarm, night lighting, and scheduled toileting. Rationale. Multimodal non-pharmacologic strategies reduce falls while preserving dignity. A. Routine sedatives increase delirium and fall risk. B. Locking doors is unsafe and violates rights. C. Removing devices increases risk. D. Question 18. During a handoff, which statement best models safe communication? A. Mr. Rahman, DOB March 1560, has a new fever. Blood cultures pending. Call provider if temp greater than 38.5 degrees Celsius. B. He's fine, just watch him. C. I think he might be sick. D. Room 12 needs meds. Answer. A. Mr. Rahman, DOB March 1560, has a new fever. Blood cultures pending. Call provider if temp greater than 38.5 degrees Celsius. Rationale. Clear, specific, patient identified. Actionable information supports safe handoffs. A. Vague statements lack critical details and action thresholds. B, C. Using room numbers risks misidentification. D. Question 19. Which practice minimizes transcription errors with verbal orders? A. Read back and verify the order with the prescriber. B. Write quickly and finalize later. C. Rely on memory for details. D. Skip spelling confirmation of drug names. Answer. A. Read back and verify the order with the prescriber. Rationale. Read back confirms accuracy, reducing miscommunication. A. Haste and memory reliance increase error risk. B, C. Drug name confirmation prevents look-alike or sound-alike errors. D. Question 20. For a patient on contact precautions, which step prevents cross-contamination when exiting the room? A. Remove gloves, perform hand hygiene, then remove gown and perform hand hygiene again. B. Keep gloves on until reaching the hallway. C. Remove PPE outside the room for convenience. D. Only change gloves between tasks. Answer. A. Remove gloves, perform hand hygiene, then remove gown and perform hand hygiene again. Rationale. Proper doffing sequence with hand hygiene at each step prevents contamination spread. A. Wearing gloves outside spreads pathogens. B. Removing PP outside risks environmental contamination. C. Glove changes alone are inadequate. D. Question 21. A 68-year-old with suspected sepsis has blood pressure 86/50, heart rate 118, respiratory rate 26, temp 39.2 degrees Celsius, SpO2 92% on room air, and confusion. What is the priority initial intervention? A. Begin 30 milliliters per kg IV crystalloid bolus. B. Start broad-spectrum antibiotics after review of prior cultures. C. Apply oxygen via nasal cannula at 2 liters per minute. D. Obtain CT scan to identify the source. Answer. A. Begin 30 milliliters per kg IV crystalloid bolus. Rationale. Hypotension and altered mentation indicate septic shock. Immediate fluid resuscitation. 30 milliliters per kg isotonic crystalloid is the priority to restore perfusion. Antibiotics are urgent, but follow hemodynamic stabilization, ideally after obtaining cultures. Delaying fluids risks worsening shock. Oxygen may be needed, but does not address perfusion first. CT can wait until the patient is stabilized. Question 22. Before administering empiric antibiotics for suspected sepsis, which action best supports antimicrobial stewardship while maintaining timely care? A. Obtain 2 sets of blood cultures from separate sites. B. Delay antibiotics until culture results return. C. Give narrow-spectrum antibiotics to reduce resistance. D. Start antifungals empirically with antibiotics. Answer. A. Obtain 2 sets of blood cultures from separate sites. Rationale. Drawing appropriate cultures before antibiotics improves pathogen identification and stewardship without delaying therapy, which should be started promptly after cultures. Waiting for results delays life-saving treatment. Narrow spectrum may be inappropriate without a known organism. Empiric antifungals are not routine unless specific risk factors are present. Question 23. A patient in septic shock remains hypotensive after 30 milliliters per kg fluids. MAP is 58 millimeters of mercury. What is the next best intervention? A. Initiate norepinephrine infusion. B. Increase crystalloid bolus to 60 milliliters per kg. C. Start dopamine for renal perfusion. D. Administer IV hydrocortisone immediately. Answer. A. Initiate norepinephrine infusion. Rationale. Persistent hypotension after adequate fluids indicates vasopressor need. Norepinephrine is first line to target MAP greater than or equal to 65 millimeters of mercury. Excess fluids risk overload without benefit. Dopamine increases arrhythmia risk and is not preferred. Steroids are reserved for refractory shock after vasopressors and fluids fail. Question 24. Which finding most strongly suggests early tissue hypoperfusion in sepsis? A. Serum lactate 4.2 mol per liter. B. Hemoglobin 13 gram per deciliter. C. WBC 9000 per microliter. D. Sodium 138 mol per liter. Answer. A. Serum lactate 4.2 mol per liter. Rationale. Elevated lactate indicates anaerobic metabolism and hypoperfusion, guiding resuscitation and risk stratification. Normal hemoglobin, WBC, within reference, and normal sodium do not reflect perfusion status. Question 25. For a febrile patient with suspected sepsis, which nursing action optimizes antibiotic timing and diagnostic yield? A. Draw cultures, then administer antibiotics within 1 hour. B. Give acetaminophen before cultures to reduce fever. C. Start antibiotics, then draw cultures within 3 hours. D. Obtain urine culture only, as blood cultures are less useful. Answer. A. Draw cultures, then administer antibiotics within 1 hour. Rationale. Cultures prior to antibiotics maximize pathogen identification. Timely antibiotics within an hour reduce mortality. Antipyretics don't replace the need for cultures and can mask symptoms. Delayed cultures after antibiotics reduce yield. Blood cultures are essential in suspected sepsis. Question 26. A patient with pneumonia and sepsis has rising oxygen needs and increasing work of breathing. What is the nurse's priority? A. Notify provider for early airway assessment and possible escalation. B. Increase IV fluids to improve oxygen delivery. C. Encourage incentive spirometry hourly. D. Switch to oral antibiotics to reduce IV complications. Answer. A. Notify provider for early airway assessment and possible escalation. Rationale. Worsening respiratory status warrants prompt escalation, for example, high-flow oxygen, non-invasive ventilation, or intubation, to prevent respiratory failure. Fluids do not treat hypoxemia directly. Incentive spirometry is supportive but insufficient in acute deterioration. Oral antibiotics are inappropriate in unstable patients. Question 27. Which set of orders aligns with the sepsis bundle within the first 3 hours? A. Measure lactate. Obtain blood cultures. Start broad-spectrum antibiotics. B. Start DVT prophylaxis. Order echocardiogram. Begin tube feeding. C. Schedule daily weights. Order chest physiotherapy. Begin PT consult. D. Administer PRN diuretics. Monitor intake or output. Limit IV fluids. Answer. A. Measure lactate. Obtain blood cultures. Start broad-spectrum antibiotics. Rationale. Early bundle elements include lactate measurement, cultures prior to antibiotics, and prompt broad-spectrum therapy. The other sets do not constitute core early sepsis bundle actions and may be secondary or unrelated. Question 28. A patient in septic shock on norepinephrine has cool extremities and a MAP of 62 millimeters of mercury. Urine output is 10 milliliters per hour. What additional intervention is most appropriate? A. Add vasopressin to support MAP. B. Start a beta blocker to lower heart rate. C. Restrict fluids to prevent edema. D. Begin hemodialysis immediately. Answer. A. Add vasopressin to support MAP. Rationale. Vasopressin is an adjunct vasopressor in refractory septic shock to help reach MAP greater than or equal to 65 millimeters of mercury and improve perfusion. Beta blockers are not routine in acute septic shock. Fluid restriction may worsen hypoperfusion. Dialysis is indicated for severe AKI with criteria, not solely oliguria in shock without further evaluation. Question 29. Which assessment best screens for high risk of poor outcome at the bedside using QSOFA? A. Respiratory rate greater than or equal to 22, altered mentation. SBP less than or equal to 100 millimeters of mercury. B. Temp greater than or equal to 38.0 degrees Celsius. Heart rate greater than or equal to 100 beats per minute. WBC greater than or equal to 12,000 per microliter. C. MAP greater than or equal to 70 millimeters of mercury. SpO2 greater than or equal to 94%. Urine greater than or equal to 0.5 milliliters per kg per hour. D. Platelets greater than or equal to 150,000 per microliter. IN are less than or equal to 1.2. Bilirubin less than or equal to 1 milligram per deciliter. Answer. A. Respiratory rate greater than or equal to 22, altered mentation. SBP less than or equal to 100 millimeters of mercury. Rationale. QSOFA uses respiratory rate, altered mental status, and systolic blood pressure to identify patients at risk of poor outcomes outside the ICU. The other sets reflect SIRS criteria or general stability markers, not QSOFA. Question 30. In suspected urosepsis with indwelling urinary catheter, which nursing action supports source control? A. Replace the urinary catheter with a new sterile catheter. B. Clamp the catheter to measure bladder pressure. C. Increase oral fluids to flush bacteria. D. Avoid manipulating the catheter to reduce contamination. Answer. A. Replace the urinary catheter with a new sterile catheter. Rationale: catheter exchange removes biofilm and reduces bacterial load while maintaining drainage. It also allows proper urine culture from a fresh catheter. Clamping is not indicated. Oral fluids alone do not control source in catheter-associated infection. Avoiding manipulation ignores the need for source control. Question 31. Which laboratory trend most strongly suggests disseminated intravascular coagulation (DIC) in sepsis? A. Falling platelets and prolonged point INR. B. Elevated hemoglobin and hematocrit. C. High LDL cholesterol. D. Normal fibrinogen levels. Answer: A. Falling platelets and prolonged point INR. Rationale: DIC is characterized by thrombocytopenia, prolonged coagulation times, low fibrinogen, and elevated D-dimer. Falling platelets with prolonged point INR raise concern. Elevated H and H suggests hemoconcentration but not DIC. LDL is unrelated. Normal fibrinogen argues against DIC. Question 32. A 42-year-old with septic shock remains hypotensive despite norepinephrine at moderate dose and fluids. Extremities are warm, bounding pulses, and wide pulse pressure. What type of shock physiology is most prominent? A. Distributive vasodilatory shock. B. Obstructive shock. C. Cardiogenic shock. D. Hypovolemic shock. Answer: A. Distributive vasodilatory shock. Rationale: warm extremities and wide pulse pressure suggest vasodilation typical of distributive shock, septic. Obstructive and cardiogenic shock typically present with cool extremities and low output. Hypovolemia improves with fluids and lacks vasodilatory signs. Question 33. For a patient with suspected sepsis and penicillin anaphylaxis history, which antibiotic strategy is most appropriate? A. Initiate non-beta-lactam broad-spectrum coverage tailored to source. B. Administer high-dose penicillin with antihistamines. C. Avoid antibiotics until allergy testing is completed. D. Use any cephalosporin. Cross-reactivity is impossible. Answer: A. Initiate non-beta-lactam broad-spectrum coverage tailored to source. Rationale: in severe penicillin allergy, select effective non-beta-lactam options, for example, aztreonam or fluoroquinolone plus MRSA coverage if indicated, while maintaining timely therapy. Administering penicillin risks anaphylaxis. Delaying antibiotics is dangerous. Cephalosporin cross-reactivity can occur in certain cases. Caution is warranted. Question 34. A septic patient's lactate decreases from 5.0 to 2.4 mol per liter after resuscitation. MAP is 68 millimeters of mercury. Urine output 0.7 milliliters per kg per hour. What does this most likely indicate? A. Improved tissue perfusion with effective resuscitation. B. Worsening shock requiring more fluids. C. Liver failure causing low lactate. D. Laboratory error requiring repeat test only. Answer: A. Improved tissue perfusion with effective resuscitation. Rationale: lactate clearance suggests improved perfusion when accompanied by stable MAP and adequate urine output. Worsening shock would increase lactate. Liver failure typically elevates lactate, not lowers it. No evidence indicates lab error. Question 35. What is the best nursing action to prevent central line associated bloodstream infection in a septic patient requiring vasopressors? A. Perform chlorhexidine skin antisepsis and maintain a sterile field during insertion. B. Use povidone iodine without sterile technique to reduce cost. C. Flush the line hourly with heparin regardless of protocol. D. Change the central line daily to prevent biofilm. Answer: A. Perform chlorhexidine skin antisepsis and maintain a sterile field during insertion. Rationale: maximal sterile barrier precautions and chlorhexidine antisepsis reduce CLABSI risk. Povidone iodine is less effective and sterile technique is essential. Heparin flushing is not standard for infection prevention. Routine daily line changes increase risk without benefit. Question 36. Which parameter best guides titration of vasopressors in septic shock? A. Maintain MAP greater than or equal to 65 millimeters of mercury. B. Keep SBP greater than or equal to 150 millimeters of mercury. C. Achieve heart rate less than or equal to 70 beats per minute. D. Target SpO2 of 100% on room air. Answer. A. Maintain MAP greater than or equal to 65 millimeters of mercury. Rationale. MAP greater than or equal to 65 millimeters of mercury is the standard perfusion target to ensure organ blood flow in septic shock. SBP targets are less relevant. Heart rate is not the primary titration parameter. Oxygen saturation is important but unrelated to vasopressor titration. Question 37. A patient with septic shock is started on norepinephrine via peripheral IV due to emergent need. What is the safest nursing step until central access is obtained? A. Use a large bore proximal vein and monitor the site closely for extravasation. B. Place the infusion in a hand vein with a small catheter to protect arteries. C. Stop the infusion until a central line is placed. D. Rotate the IV site every hour to reduce risk. Answer. A. Use a large bore proximal vein and monitor the site closely for extravasation. Rationale. If peripheral vasopressors are used temporarily, a large bore catheter in a proximal vein with vigilant monitoring reduces extravasation risk. Hand veins are higher risk. Halting life-saving pressors is unsafe. Hourly rotation is impractical and increases complications. Question 38. Which action best addresses hyperglycemia and sepsis to support outcomes? A. Implement insulin protocol to maintain glucose in a moderate target range. B. Allow glucose greater than 250 milligrams per deciliter to ensure energy availability. C. Begin strict fasting to reduce insulin needs. D. Administer glucagon to stabilize blood sugar. Answer. A. Implement insulin protocol to maintain glucose in a moderate target range. Rationale. Controlled glucose management, avoiding both hypoglycemia and severe hyperglycemia, improves outcomes in sepsis. Permissive hyperglycemia worsens infection and recovery. Fasting is inappropriate in critical illness. Glucagon raises glucose and is contraindicated. Question 39. A postpartum patient develops fever, tachycardia, uterine tenderness, and foul lochia. Suspected septic endometritis is diagnosed. Which nursing priority supports timely management? A. Obtain blood and endometrial cultures before starting broad-spectrum IV antibiotics. B. Begin oral antibiotics and schedule outpatient follow-up. C. Delay antibiotics until ultrasound confirms retained products. D. Apply heat packs to the abdomen and reassess in 24 hours. Answer. A. Obtain blood and endometrial cultures before starting broad-spectrum IV antibiotics. Rationale. Cultures prior to prompt IV broad-spectrum antibiotics address source and timing. Imaging or supportive measures should not delay therapy. Oral antibiotics are inadequate for sepsis. Waiting for ultrasound risks progression. Heat packs are supportive only. Question 40. A patient with suspected sepsis shows new confusion, oliguria, and rising creatinine. Which interpretation best guides nursing actions? A. Evolving organ dysfunction requiring escalation and close monitoring. B. Stable sepsis without need to change plan. C. Pure psychiatric delirium unrelated to sepsis. D. Isolated dehydration that will resolve without intervention. Answer. A. Evolving organ dysfunction requiring escalation and close monitoring. Rationale. New CNS and renal dysfunction indicate worsening sepsis severity, warranting aggressive management, frequent reassessment, and multidisciplinary escalation. Labeling it stable, psychiatric, or benign dehydration risks misdeterioration. If you found this video helpful, don't forget to like, subscribe, and share with your fellow nursing students. Hit the bell icon so you never miss an update. See you in the next one. Happy studying.